Conn syndrome. The opposite of Addison's. Really? What's Conn's? It's a primary tumor located in adrenal cortex. Where? Does it produce too much cortisol? Listen, if you produce too much cortisol, how could you call that Conn's? You cannot. So if you produce too much cortisol, that automatically puts you into the category and disease of, and this is how black and white it is, of Cushing syndrome. This is Conn syndrome. Therefore, all I have is too much. Look at the first statement. A benign adenoma of the zona glomerulosa. So therefore, resulting in, you tell me, sodium. Quickly, come on. Good, increased sodium. Give me lab, increased greater than 145. Next, potassium. Too much aldosterone, you're getting rid of it. Hypokalemia, potassium, less than 3.5. Tell me about pH. Increased, you're getting rid of your hydrogen. That's probably one that's a little tricky. So whenever you go through acidosis, just make sure that you walk through that for me, okay? So remember, too much aldosterone, you get rid of hydrogen. I'll agree with you there. That gets a little tricky. But with the sodium, potassium, that should be reflex. So with Conn syndrome, you can expect to see metabolic alkalosis. Increased excretion of potassium, hypokalemia. We talked about all this. Look at this. Resting membrane potential. One more time. RMP. Close your eyes. Work with me. Don't just look at the words here. Conceptualize. Your potassium has been lost, hypokalemia. Resting membrane potential. More negative or more positive, please? More negative. What do you call that? If it becomes more negative, you do not call that depolarization. Look at what it says. Hyperpolarization. Okay? So, if you become more negative, who is? The resting membrane potential, you're where? Further away from threshold. Are we clear now? So therefore, what happens to your muscle? It's much more difficult to have an all or none type effect. Therefore, you will have muscle fatigue. Increased hydrogen secretion with Conn syndrome, metabolic alkalosis. Now you tell me, with all that sodium that we have here in Conn's, what kind of hypertension? It's not primary. It's secondary. So would you think that Conn syndrome is not common? Just the opposite. It is common. So it would behoove you to really know Conn syndrome in great detail. It would behoove you to know aldosterone in great detail. Hence, all the time that we have spent really laying down the foundation of aldo. Cons here, excess sodium. You're going to have, all right, let me ask you this one. This one's neat. Watch this. You have increased effective arterial blood volume. Not again, Dr. Raj. Yeah, I am. I have to, all right? So let's do this. You have too much effective arterial blood volume. What does that even mean to you? It's the plasma component, right? So you have all this blood coming to the kidney, afferent arterial, increased. Right now, skip over the glomerulus for me. I want you to enter the efferent arterial, and then I want you to enter the peritubular capillary. What happens to the hydrostatic pressure in the peritubular capillary with all of this blood volume? It increases. So what happens to reabsorption? It decreases because you're offering resistance, right? So with increased effective arterial blood volume, what happens to your filtration fraction? Good. It decreases. We talked about that earlier. If you're not clear about that, I have given you specific slides about effective arterial blood volume and one in which we had a decrease effective arterial blood volume. Examples, hypovolemia, maybe due to hemorrhage, or maybe due to congestive heart failure. Do you remember that? And the opposite. I gave you examples clinically of increased effective arterial blood volume, and the headline of one of the causes was mineralocorticoid excess. What's Conn syndrome? Mineralocorticoid excess. Stroke volume, increased systolic blood pressure. Peritubular capillary, there it is. This then explains the filtration fraction. If you have too much volume, don't you want to get rid of your sodium? Of course you do. Enhancing clearance of your sodium. Prevents the proximal tubule from reabsorbing sodium. What then happens to your filtration fraction, please? Diminishes. RAS. Now, pay attention here. This we haven't talked about, but is important. Oh, yeah. So this is primary hypoaldosteronism. Who controls or regulates your aldosterone? Now, if you say ACTH, I'm not going to come out there and slap you. Close. No, I'm not. But you begin the process, all right? The cascade begins with ACTH. Picture this, all right? Now, okay. Get serious. Focus. ACTH, anterior pituitary. Adrenocorticotropic hormone. Comes into your blood, through the blood, hits the adrenal cortex. I agree. Next, rate-limiting enzyme, desmolase. Fantastic. Adrenal cortex. Where am I? Glomerulosa. So, granted, you begin the cascade of your adrenocortical hormones with ACTH. I'll give you that. Who finishes the job? There you go. Renin, renin, renin. So therefore, for aldosterone, the key regulator in terms of feedback is going to be what's known as plasma renin activity. Please, this is what you want to know clinically. Everything else, of course, things could be technical, but I'll tell you when to be technical and when to be clinical. I'm asking you kindly to be clinical with me. So if you have too much aldosterone, you're going to shut down plasma renin activity. Because why? The tumor, a benign tumor in the adrenal cortex, is producing too much aldosterone without even the need and the help and assistance of your renin. That's important. Next. Excess sodium enters smooth muscle. But what does it cause it to do? Then there might be increased arteriolar pressure or resistance. It opens up calcium channel. Boom. We have increase in TPR. What do we have? Increase in diastolic blood pressure. And these are the pathophysiologic explanations as to why you have an increase in systolic blood pressure with increased volume in sodium and increased diastolic blood pressure because of increased total peripheral resistance of the arterioles. Put it all together. Here you have it. You cannot miss a question from all the way down from basic sciences all the way up to your patient and presentation. Summary: hypertension, polyuria, muscle weakness, hypernatremia, hypokalemia, metabolic alkalosis. We walk through all this in great detail. Now, in your head, as you go through each one of this, because you, as a resident, medical student, what have you, you walk into rotation and you see these things and you're explaining to your attending or to even your patient or your colleagues, this is what's going on. They will hoist you onto their shoulders and parade you around in the rotation. How good do you feel? Pretty nice. Decreased PRA. What's that mean? Plasma renin activity with primary hypoaldosteronism. What if you find an increase in renin? What would you call that, perhaps? Secondary hyperaldosteronism, correct? Give me an example. A decreased perfusion to the kidney. You find this to be interesting. I want you to focus upon the graph. There are three parameters on the y-axis here. All right, three different phases. Mean arterial pressure, cumulative sodium balance, urinary sodium excretion. There's an important concept that that medicine wants you to know, okay? Really is. And it's called aldosterone escape. We know it occurs because this is how patients present. That's why I have to give this to you. And it occurs very common because I told you Conn is found to be common. On the x-axis are days. So let's say right in the middle, now this is an experiment to give you an understanding of Conn. In the middle is aldosterone. You see that? In the middle is aldosterone that's been given. Immediately, take a look at the mean arterial pressure shooting up. That's what you're paying attention to right now. Listen to what I'm saying, and I'm going to walk you through this. What's interesting, too, is the fact that sodium actually is going to decrease amazingly. So even if you have Conn syndrome and you have increase in aldosterone, granted, overall, listen, overall, your sodium in your body is going to increase. Thus, the blood pressure will remain elevated as long as aldosterone is present. However, the way that the kidney works is the fact that you have a phenomenon called aldosterone escape, where for aldosterone over the next few days, take a look at the x-axis, what then happens to urinary sodium? Take a look at the bottom phase here. The bottom phase, the third bottom one, the urinary sodium. It quickly increases and you diurese your sodium. Is this clinically relevant? Oh, yes. This is how your patient is going to present. Let me ask you something. Would you most likely find pitting edema in Conn syndrome? No, not necessarily. That's why this experiment was necessary, so that you clearly understand as to why you might not, actually not that you might, you will not find pitting edema and Conn syndrome as you would with congestive heart failure. In congestive heart failure, that's it. You have continuous death of the heart, There's going to be systolic dysfunction, and every single time aldosterone removes that fluid, it keeps going into the interstitium because it can't move forward. Are we clear? Especially with right-sided. In Conn syndrome, your heart's perfectly fine. In Conn, it's a problem with the aldosterone in the adrenal cortex.